This is the February meeting of the League of Women Voters, the Healthcare Issues team. And for those of you who are not familiar with our group, as our name suggests, we're interested in healthcare and try to keep ourselves informed about healthcare issues. Because of the large number of people attending today, the format of the meeting will be just a little bit different than the usual. We're going to ask that you put your questions in the chat so that as many people as possible have an opportunity to ask questions. Leslie has offered to follow up with questions that we might have, so I will forward them to her, and she will get them back to you, and I will get the answers back to you if we don't get to all the questions. But we're here today to learn about the palliative care program at Peace Health, what it is, how it is like the previous palliative care program, how it differs. I'm sure there's going to be many questions, and we are very grateful to the speakers for coming here today. We very much appreciate that. I know we all have strong opinions about this, and some of the questions that might be raised will be difficult. But I know that, as you've always done, your questions will be asked very respectfully. The League always encourages civil conversations about issues, and we're here today to learn about things. So with that, I'd like to introduce our presenters. Donna Ingalls, Peace Health Foundation Vice President and Outpatient for Palliative Care Liaison. Amber Abstropson, and I've probably mangled her name terribly, but she's the Chief Development Officer, St. Joseph's Foundation, and she can correct her name when she's speaking. And then Leslie Clements has also joined us. She's the Systems Director for Palliative Care. So with that, I'm going to turn this over to them. And they can, if they want, they can fill you in a little bit more about who they are and their experience, and begin to tell you about palliative care at Peace Health. So who would like to start here? Okay. Donna, you're muted.
So sorry. Okay, can you hear me?
I can hear you now, yes.
Great. So I wanted to start by thanking everybody for making the time to be on this call today, for making space for us to have a conversation that I know is very important to the community. And I know that I speak for Amber and Leslie and myself when we say that we're really looking forward to this and to sharing the good news about what's going on with our program. Do you have the first slide, Amber?
Yes, I do. I will start right now. Sorry, okay. I was just trying to get that figured out. And can you all see my screen?
Not yet.
Not yet?
Not yet.
Okay. Let's try this.
Great.
Perfect.
Great.
Perfect.
Awesome.
Yeah.
So just so everybody has a little bit better picture of who we are, Leslie Clements is the System Director for Palliative Care. She has a very long, her life's work has really been in palliative care. She's been in it for 20 plus years. She's been 10 years of leadership in palliative care, 7 years with Peace Health. She is very instrumental in the program that we will be talking about today, in the build of this program and the feel of it and the management of how it goes forward. So this is a huge opportunity for us to have Leslie here with us, because she can really talk about the nuts and bolts of the program in a very granular way. Again, my name's Donna Ingalls. I've been on the foundation board for coming on about 8 years. I came on the board with a passion project of helping to bring outpatient palliative care to our community. So this is a program that's very near and dear to my heart. I was the outpatient palliative care campaign chair when we fundraised for the initial program and dreamed the big dream of what we wanted that program to look like. And since last spring, when the program was cut and changes were made, in this rebirth, am now the outpatient palliative care liaison between the foundation and all of the all of the Peace Health, different entities from executive leadership all the way down to I have regular meetings with our local caregivers. So that's my role. And then Amber Aspa-Jorson is the Chief Philanthropy Officer for St. Joe's Peace Health Medical Foundation Board. And I will just say that a little aside that Amber came in as our new philanthropy officer right when this program imploded last year. And she has proven to be a phenomenal steward of the philanthropy office. And she has just done a remarkable job of hanging in here and helping us get this program over the finish line. So I think it's important for everybody to know that the arm of philanthropy in this community is really in good hands.
Thank you so much for that, Donna. That was really nice. Well, let me see if I can figure out how to progress my screen. Okay, there we go. As Donna said, I'm Amber Asbjornson. I just started in my role as Chief Philanthropy Officer at Peace Health about a year ago. And before that, I spent almost 20 years at Western Washington University in philanthropy there. I've lived in Whatcom County for nearly 25 years and have just absolutely loved taking over the reins at the foundation here at St. Joe's and the Northwest Network to be closer to the community that I live in. And it's an honor to serve you all. And I'm really grateful that you've given us an opportunity to be here today and share about some of the really important work we've done. And the exciting news, I think we come bearing really great news today. I just wanted to set the tone by giving you an overall picture of Peace Health, the system, and also Peace Health in Whatcom County. So we're starting big. As you all know, it's a nonprofit Catholic health system. It serves Washington, Oregon, and Alaska. We have 17,000 caregivers, 1,155 physicians and providers, 9 medical centers, 1,600 beds, 167 primary and specialty care clinics, and 1.88 billion in payroll annually. This is an overview of our networks of care. So you can see the Northwest Network is up here. It includes Whatcom County, San Juan County, Skagit County, and also Ketchikan, Alaska. Then we also have the Columbia Network. That's Cowlitz County and Clark County. And then the Oregon Network, which is Lane County and Cottage Grove, Oregon, and Florence, Oregon. As for Peace Health in Whatcom County, we have 3,300, almost 3,400 employees. This was last fiscal year, which was July 1st, 2022 through June 30th, 2023. 14,666 patients served. Almost 70,000 emergency department visits, 8,339 surgeries performed, 1,800 babies delivered. In fact, they just played the chime. I don't know if you know this. This is my favorite thing about working at Peace Health. Every time a baby's born, they play a chime over the loudspeaker for everybody to hear who's working in the hospital. So it's always a great reminder that life is happening all around us. 241 licensed hospital beds, 286 active medical staff, 25 primary and specialty clinics, and 390,706 clinic patients served. Palliative care is a part of the home and community division, so I just wanted to share a quick slide about the other programs that are also a part of home and community. We have home health, home infusion, and hospice. Home and community provides a broad range of personalized clinical and rehabilitative services to patients in the comfort and convenience of their own homes. And with that, I'm going to hand it over to Leslie to do a little bit more of a introduction of who she is and how she's involved with the program.
Thank you so much, Amber. And thank you to the Women's League of Voters for having me come and talk to you all today. Such a great privilege to talk about this amazing and very sacred work that we do and we've all been so deeply invested in. So again, thank you for that opportunity. My name is Leslie Clements. my clinical background is in social work. So I have a master's in social work. I'm also a licensed clinical social worker. And I have a MBA, so master's in business, with a focus on healthcare administration. I have 20 years of palliative care experience. So this is my life's work. This is my why. This is what gets me out of bed every morning. To me, this is bigger than a job. And I know a lot of people, most of our clinicians feel the same way. This isn't just something you get up and do every day. This is a mission. This is mission-driven work to serve chronically ill patients that otherwise we know are just at a high likelihood to fall through the cracks. And even for people who are very familiar with healthcare, navigating a healthcare system is very complicated. I had to schedule an appointment for my daughter this morning, and I got transferred to 4 different people, and I am a healthy, well-functioning person who's worked in healthcare for a long time. So imagine being chronically ill, it not being where you work, and being uncomfortable and in pain, and trying to seek out help. And so palliative care is really designed to help people navigate this and walk alongside their chronic illness journey. Of those 20 years, 10 of those years have been in palliative care leadership, which is such a great honor to serve the people who serve the people and really do everything I can to make their work easier, and effective and efficient and sustainable. Sustainability both for leaders and caregivers from an emotional and well-being and health standpoint is critical. Our biggest asset is our workers. And so happy, well cared for workers do better work for our patients and families. And that's really what we want to see. I've had the great honor of working for Peace Health for the last 7 years, all within palliative care leadership. I've been the manager for the Columbia Network. So that is inpatient and outpatient and clinic work there, all 7 of those years. I have had various hats put on me over the 7 years where I did a stint as the system inpatient palliative care director. So I'm familiar with the inpatient Bellingham team and the inpatient team in Eugene as well. And then I got pulled in to all of the outpatient programs across the system. So Eugene, Vancouver, Longview, and Bellingham to help implement the model that I have been running and had upstanding in Vancouver for 3 years now, which is what we'll be talking about some today. I am a member of the Center for the Advancement of Palliative Care and the Palliative Care Quality Collaborative, which are 2 biggest nationwide programs and organizations to support the growth of palliative care. These memberships are critical and have been very valuable. And from a national standpoint, Peace Health is a leader in palliative care. So I have people from both of these organizations call me regularly to do consults, to pull me in to talk to other palliative care programs across the nation about the wonderful work we're doing here at Peace Health and a lot of the innovative things we've been able to stand up. And so we help other programs nationwide stand up new models, new programs with a focus of caregiver wellness and sustainability.
Great. Thank you. So I'm going to hand this one over to Donna, and then I will jump in for the last bullet point there.
So what we really want to talk about is how the new program is set up, some of the differences that are, between where we are now and where we are last year. And I think the important part of this is to know that the foundation is very committed. I would like to be real clear that from the day that we learned on the foundation board last year that the program was being cut, the foundation really activated quickly. Everybody on the board was galvanized in their desire to have to have a meeting as soon as possible with senior leadership, and we really worked and banded together to make sure that we made our case that it was important for Bellingham to continue to have an outpatient palliative care program. There was never any light of day amongst any of us or the effort that we put in to make sure that we did everything we could to try to bring this program back. So the foundation is very committed to this. And, you know, in the iteration that it is now, it is a true partnership with Peace Health. And Amber can speak really clearly how the dollars are, but I think it's important for everybody to know that we are really married in a partnership with Peace Health to make sure, and Peace Health is very committed to this program, as is the foundation, to make sure that it's a sustainable financially program and that it's a sustainable program for the people that are working in it, and that we serve as many people as we possibly can, as well as we possibly can. So the people that are in it now, Dr. Melissa Edwards is taking over for Dr. Scott Foster. Some of you may have heard that Dr. Foster has recently resigned. He was the chief executive for the medical group, and he's someone that I have worked with very closely this last year. He was the person at the executive level that took on the bulls by the horns, so to say, when we were given the green light to start reinventing a program. Dr. Foster championed that. He has worked very closely with us. I have been in meetings, many hours of meetings with Dr. Foster, and have weekly conversations with him and his team. And while the foundation is not involved in the clinical aspects of the care, we are very much at the table, knowing what's going on with the program, how we're going to make this work best for what Bellingham's unique needs are, and because we have a very palliative care literate community, what that looks like different than maybe some other communities would be able to, what they would tolerate as far as a program. So we have had a lot of input in that way. Dr. Foster resigned for personal reasons, had nothing to do with Peace Health or his desire to work there. He's making a huge life change because he has aging parents, and his need to care for them, something I think anybody that's in this conversation can appreciate. So now Dr. Melissa Edwards will be doing that. I'll continue to have regular contact with her. We really have weekly conversations and complete access. Leslie Clements is now the system director and is just, as I think you can kind of see, she's a firestorm and just loves this work so much. So it's a huge asset for us to have here in Bellingham, her support. Amber as the development officer, and then I as the liaison will continue to advocate for what the foundation and vis-a-vis the community, I think, wants, in our program, to make sure that it looks like and feels like something we feel good about.
Thank you, Donna. There have been a lot of questions around how we're funding the program now, and so I'm going to share a bit about what this partnership looks like between the foundation and Peace Health. And it really is a true partnership, and I think you can see that in Donna's role that she's playing as a volunteer on our board, who also has direct access to the people who are running the program. I just have to give a shout out to Donna. This was definitely a team effort, but it was all led by Donna. She is an extremely valuable leader in this community, and her passion around palliative care really speaks for itself. I would often joke to her that this was an overtime volunteer position that she wasn't getting paid for because Donna has worked tirelessly over the last year on behalf of this community for this program. The way that we're supporting the program through the foundation is through a multi-pronged approach, which will focus on the current needs and also the long-term needs for sustainability. We had some funds that we still hadn't spent from our previous fundraising initiative around palliative care, so we plan to use those funds first. At our meeting in the spring of the board last year, or actually it was this summer, the board decided to allocate $1 million from unrestricted funding to a palliative care fund that will support the next 4 to 5 years of the program. We also decided to establish a quasi-endowment, which was a board designated endowment to start to build long-term sustained funding for the program. This is all before we go out to the community and start to ask for money to support the program, because we really feel like we have an obligation and some due diligence to do in this time right now. in our partnership to pull the program back together, make sure it's working, get to the point where we feel really solid about our ask and that we feel like this program is up and running and we can, you know, come out and actually say, yes, this is happening. This is great. We think it's going to be. But before we ask our community to support, we've decided as a foundation to use our current funding to make that support possible now. I also just want to say that as a foundation board, we take our donations from our community very seriously. Our donors are investors, and especially when it comes to a program like this, where there is a very unique partnership between donors and Peace Health, I think there have been some very significant lessons learned about how you know, like Donna said, we're not involved in the clinical aspect, but we are partners. And so the conversations we've had with our system leaders and our local leaders about what that partnership looks like, how much information we really can get, what we can share with our donors, and making sure we're stewarding those monies the best that we can. I just want to say our commitment to you as our community members and our donors is that you know, we're really paying close attention to this one and quite involved, as you can see through Donna's role and Leslie and my role also as being a part of the team. Okay, and then back to you, Leslie.
Yeah, thank you. So with the support of the foundation, we are working on building our outpatient palliative care program in Bellingham. The model is a little bit different than our previous model, so I'd like to take a minute and talk about that just so you guys know what the differences are. So our previous model, we would admit people and we would carry them on our census until they were ready to transition to hospice services. Our new model is a consult-based model. So what that means is we get the referral, we identify your acute palliative care need, and we work to address that. And when your acute palliative care need has been addressed, we'll sign you off service with the understanding that should anything change, because as we know, with chronic illness, things change all the time. People's goals for themselves change, people's treatment options they have available to them change. That we ask you call us back and we'll sign you on. So the idea is instead of keeping patients for 3 to 6 months during their stable period and having that occupy a space on our census, that we have a rolling census of patients who really have acute palliative care needs. So we're meeting the highest acuity palliative care need in the community at any given time. This also really optimizes the staff that we have available to serve patients. So currently, and since May, we have had a nurse and a social worker, Katie and Devin, working in partnership with me to rebuild this program. I will say Katie and Devin are amazing. They're so committed to this work and have stayed on. And the strides that they've been able to achieve with launching at this new program are nothing short of incredible. It really takes a while to stand up a new model and a new program. And Katie and Devin were able to do that within a couple of months, just the two of them. And so I'm really proud of them. If you happen to know them or see them in the community, give them kudos. They love this work. They love Bellingham community. They love these patients, and they're just incredible. We hired a medical assistant, Drew. They started last Monday, so we're just thrilled to have that additional support. That position is critical for having a provider on board. It really optimizes their schedule. Because palliative care is reimbursed on a fee-for-service schedule and not a value-based schedule. Making sure we really optimize our provider time is a big part of financial sustainability. Since the majority of what we do, although it's all very valuable and critical work, is not reimbursable on a fee-for-service model. So making sure that we're really optimizing in that way. So the MA role is crucial for that. So we got the MA early. We know this nurse practitioner is coming in May. She has a lot of palliative care experience, particularly in the outpatient setting. So we're just thrilled to be welcoming Maggie in May. And by the time she gets here, this the MA will be up and running and ready to get her started. Our truly amazing system medical director, Dr. Angie Lee, has already stepped in to start the oncology clinic portion. So we have a community-based consult model, which I've talked about, and we also will be seeing patients in the oncology clinic. And Angie, I don't know how she does this. She is our system medical director, our local medical director in Bellingham. She does inpatient clinical work, and she is also doing a half a day in the oncology clinic to get the model set up and ready, and all of the templates and things built, and the referrals and the referral triggers all in alignment. So when the nurse practitioner starts, she can just step right into that. We also will be welcoming a half-time chaplain and a half-time pharmacist. We're so fortunate in Bellingham. Our palliative care teams are much beloved by our other service lines, and we work in great partnership with everyone. So our pharmacy team and our spiritual care department are giving us 0.5 of their available FTE to support this work, and obviously being supported by our wonderful foundation as well. And that will happen in June. So in June, we will have everybody we need in the program.
Ready for the next slide?
This is a little bit about where we were. So in 2022, the number of distinct patients, and so I want to kind of clarify what we mean when we mean distinct patients versus visits. Those are two different things. So the number of distinct patients are the individuals. The number of visits is how many visits our distinct patients get. So in 2022, before our RIF happened last year in May, we had 337 distinct patients with 1,425 clinical visits. The average number of visits per patient was 4.2. This year, so far, we have been collecting data on this new program month over month since October. So starting calendar year 2024, our goal is to have 460 to 550 distinct patients on service, 1,610 clinical visits. Our average number of visits per patient will be 3.2. So as you can see by these numbers, we will be seeing almost double the number of patients on our new model that we were seeing on our old model. Also, we will be achieving more visits in our community for these patients. And we will really be optimizing what is done in each of those visits. Here's our timeline for our implementation, which I've talked about a little bit. We are accepting referrals. Our consult-based model accepts referrals for all diagnoses. So anyone with a chronic life-limiting illness that could use additional support, whether that's community resources, goals of care conversation, advanced care planning, trajectory of care, disease, illness education, whatever the support is, as long as you have one life-limiting chronic illness, we will see you for our consult-based model. And we also do have the half day in the oncology clinic where we are seeing oncology patients with stage 4 cancer or metastatic processes. We hired our medical assistant, Drew is their name, and has over 20 years of medical assistant experience. This week she is shadowing our other team in Vancouver to really ramp up her onboarding. Currently, we have Katie and Devin and a half-day clinic with Dr. Lee, and they are seeing an enormous amount of patients, considering it is just the two of them and 2.5 of them. So we are accepting all referrals and giving patients an assessment. The nurse practitioner will be here in late May. The half-time chaplain and pharmacist will be here in June. Q&A, thank you. So I'm going to pivot over to the chat here because I already see questions coming into the chat. So I want to scroll up to the top. with Carol. Thank you for your question, Carol, which was, where does Leslie live? What was done that closed down the Bellingham Palliative Care Program? So great question. So Carol, I live in the Vancouver area, home and community. So again, that's hospice, home health, and palliative care have service line directors. So we travel across the whole healthcare system to see people in each location and each team. So I am in Bellingham once a month, I am in Eugene once a month, and I am in Vancouver once a month, and then I am available virtually all the time. I talk to Katie and Devin every week. There's a local palliative care manager on site, Claudia Fisher, who is a palliative care nurse with also 20 years experience. So she is boots on the ground managing this program. I have a weekly one-on-one with her. I have a weekly one-on-one with all of the managers. Dr. Angie Lee, our system medical director, is also in Bellingham. What was done to close down the Bellingham Palliative Care Program? So I think this is a really big question, and I'm happy to spend some time talking about it. What really happened was something bigger than outpatient palliative care in Bellingham and bigger than Peace Health. Our post-COVID financial era for healthcare is a real challenge. So 50% of the rural hospitals in our country closed over the last 2 years. Our big healthcare systems across the country are having to do mergers with each other to survive and keep their EBITDA above a certain level. The government was providing some pandemic financial support to keep lights on and doors open. And when that went away, everyone found themselves in a big hole. Again, that's not just Peace Health. That is every healthcare system across our country. Very sadly, Providence, who was really an innovator and leader for palliative care in the Pacific Northwest, they had the most robust palliative care program. They completely closed and lost their palliative care program altogether. Just tragic. And so Peace Health really fought to keep palliative care. Hospice lost staff, home health lost staff, palliative care lost staff, and every single department in our hospitals all across our system lost staff. We lost leadership at executive levels at the shared system services. We lost administration support, people, who register patients and check them in. We were already short. A lot of people in the pandemic chose to leave healthcare altogether. And so everyone in healthcare was really tasked with, you need to cut by this amount or these programs won't exist anymore. And so very sadly, we fell victim to that as well. I will say, as somebody who's worked in palliative care for 20 years, I was doing bedside palliative care before they called it palliative care. And I've seen this, right? Because we aren't money generating, we're cost savings, and we demonstrate a lot of value to patients, families, and healthcare systems. So I've seen this happen a lot. And I remember my first time, all I know how to do is show up and be authentic and transparent. So I'm just going to share my experience with you guys and my story. Over 20 years, I've seen palliative care cut a lot. I remember my first time it was cut. It is it's such heart forward work that I was really devastated, and I didn't know how I was going to be able to move on because I had invested my full self and my team had invested their full self, and everyone that championed it had invested their full selves too. So it was a whole community of people who are absolutely devastated. And then we got together and we thought, well, we can't let this be the end. We can't let this be the end because this work really matters. And I know the consequence of not having this work. This is how I started doing it, is sitting at the bedside, listening to people say things to me like, well, if I had known when I had that surgery that I would never be able to go home again, I wouldn't have done it. And I just thought, we can do better. We need to catch these people upstream. We need to hold them. We need to give them the information, and we need to empower them to make decisions that are best for them and for their lives. So every time that happens, I rally up all of the champions. I rally up all of the troops. I regroup. and say, let's keep going for these patients, right? And so I am witnessing what I have witnessed many times over, sadly, but us rallying again and coming back together. And now Bellingham will have a program that serves more people than the previous program, thanks to all of us continuing to believe and continuing to hold the light. And I, over my 20 years, no matter what difficulty has been thrown at us, no matter what punches we've taken, we have always risen. And so, again, I want to thank everyone on this call for continuing to be with us and continuing to support us in rising and serving patients. Because at the end of the day, it's the humans that are in the houses we go to, that are in the beds in the hospital, that really matter. So, Carol, I hope that answers your question. I am scrolling to Sherry. Sherry's question was, the last palliative care program was developed through philanthropy. Leslie might need some more coffee. Are you confident that people will donate to the program again, and what will guarantee this won't happen again? Sherry, that's a great question. So I'm going to spend a little bit of time here talking about how palliative care is reimbursed. I think for people who are interested in donating to palliative care, it's really important information to have. So basically anything our providers do is reimbursable. But we are a multidisciplinary team of social workers, chaplains, of nurses, MAs. And so a lot of what our other team members do are not billable time, right? Although very important, because palliative care is a holistic type of care that takes into account the entire individual and not just their medical condition. You know, we're really different in healthcare this way, where we're looking at you as a human and what matters to you. And so we need this wraparound support. Because it's not reimbursable, like I said, we're basically a value-based care service on a fee-for-service model. So there's legislation going on right now in Washington to talk about how do we make palliative care value-based reimbursed, in which case we would be doing a lot better financially, right? But on a fee-for-service reimbursement model, your provider does this thing, they can reimburse for this, and then the insurance decides how much of that to pay you. And so my job as the director here is I want to close this financial gap. We will always have a financial gap in palliative care, right? And I want to close it as much as possible. It's optimizing, payer contracts that are not Medicare. Medicare is Medicare, and they will do what Medicare does. They usually do come around and shift to what private payers are doing after the majority of them do that. So we are seeing that discussion happening in the country. It's very, very exciting. Private payers are talking about per member per month things. They are talking about value-based bundle reimbursements. So that's changing the conversation. So again, I want to take this gap between, breaking even and where we are and make it as small as possible. That being said, until Medicare pivots, because that's our biggest payer source because of our patient population. 80% of the patients served in palliative care are Medicaid and Medicare patients. And so there's always going to be this gap. So what you do is you really think about what makes the program most sustainable, right? So this is one of the reasons we are hiring a nurse practitioner and not a doctor. The nurse practitioner has the same billing capabilities as a physician, but costs around what a nurse would cost. So that is just a financially sustainable decision. Social workers can reimburse for some end-of-life counseling, right? So they have reimbursement opportunities only in our outpatient setting. So making sure you have the social workers there to back up. You want the providers to see the most acute patients, do those initial consults, because that's what's going to reimburse best. But that doesn't mean they're done with the care. So then we're sending out nurses and social workers to tuck in so we can get those providers doing those big charge drops, right? And that's what optimizes them. The other thing that is we're so very fortunate is we live within home and community. So home and community has an overall EBITDA target that we need to meet. And so although palliative care is here, right, home health comes here, hospice comes here. So home health and hospice know we are some of their biggest referral sources, particularly hospice. We are their biggest referral source. We also know that patients who receive outpatient palliative care services and then go to hospice have an average of 40 days longer on hospice than patients who are referred directly to hospice without palliative care. So there is a portion of hospice revenue we directly contribute to. And so that is kind of what then helps us break even, right? And so I look at this because there are humans involved. Palliative care is very human work. I'm focused on the humans that do the work and the humans that receive the care. Um, our caregivers are our biggest resource, right? So there are humans involved in this. So making sure I hire people that are as sustainable as possible, given the positive EBITDAs the other two areas make that can make up for this. And luckily they believe in us so much and know we refer to them and benefit their services as well, that they're willing to do that. So I think, what if foundation wasn't there tomorrow? And you know, truth be told, I've worked with foundations across the system for a long time where they say we will do this for a certain amount of time, which is great, right? It helps us start up, it helps us get our workflows, it helps us get our routines, it helps us get settled, and we have a little bit of buffer. And that's how these things start, you know, is people believing in it. And then when it's time to take it back over, I don't want to put things in place that are not something we can absorb within the home and community EBITDA that I just described to you. So making sure we're really strategic about the disciplines we hire, who has reimbursable opportunities, and what things are in place to make those people as efficient as possible. So that when foundation support goes away, we can stand up and carry what we have. So the Bellingham program prior to this was a beautiful, beautiful program. It had multiple doctors, multiple pharmacists. I've never really seen a palliative care program like it. And with our reimbursement model, it is tricky to maintain that discipline setup. So that is something we are doing differently this time so that this will not happen again. Sherry, I hope that answered your question. Again, and if I say anything and it brings up a follow-up question for anyone, please feel free to put it in the chat. I'm going down here to Lara's question. Can people other than medical providers refer into the program? Now that's a great question. Because we do have Dr. Lee providing care, we need an order. So that's basically saying, you know, we're your primary care physician, your attending team, or your subspecialty provider, your oncologist, nephrologist, pulmonologist, right? And they know welcoming palliative care in means that, you know, we're going to be making some medication recommendations. We might be making some changes to those. So we do need an order to do that. That being said, if you call our referral line and say, you know, I am the daughter of so-and-so who's been really struggling. These are the things we're seeing. I think this would be a really helpful service for us. We will call the primary care provider and say, we've heard from this family that this is needed and think that they could benefit. We've talked to them. We agree that they could benefit. Can we please have an order? So we will help facilitate that. So we do have patients self-refer who call. We have family members who call. And then we do work on our end to help get that order to connect with the services. Leslie, what actual care is provided? That's a great question. So we're very different in terms of what our care is, right? When we think about healthcare and care, I think a lot of people think about hanging medications and following medication orders and how to properly turn someone in a bed or move somebody around. And you know, our care is our conversation, right? So we are the most specialized service in healthcare. We have to know everything about every chronic illness disease and its trajectory, what's expected, treatment options, the percentage outcome of those options given what everybody's condition and comorbidity status is. So we have to know a lot. So we really come with that knowledge to arm you. You know, when you're talking to a pulmonologist, they're going to talk to you about your lungs. When you talk to a cardiologist, they're going to talk to you about your heart. And so we're taking the big view, the big holistic view. Like your heart and your lungs aren't exactly separate from each other. They impact each other, right? And so although your cardiologist might say your heart looks a little better, your lungs don't. And that's going to impact your heart. So we're taking this big picture view of how all of this works together and having a conversation with you. Now, the other thing we do that isn't always done, healthcare's designed to fix it. That's what everyone who goes into healthcare wants to fix it, right? So you come in, you have a diagnosis, you have A, B, and C treatment options or A, B, and C medications. You're going to have a provider come in and say, you have this, these are your treatment options. What do you think? And people are like, I don't know. What do you think? Right? So we're really coming in and saying, what's important to you? Right? So if going out in your garden is important to you, if making sure you're alive to see the birth of your grandbaby is important to you, if making sure you don't give up your home is important to you, like let's talk about the treatment options on the table and how that connects to what's important to you. We want you to choose those treatment options that are best for your life. So we're really here talking about outcomes. So doctors will talk about what's available and what's happening, but not always what happens on the other side, right? So we're talking about what is the outcomes? What are the percentages of the outcomes that are going to happen on the other side? So it's a lot of goals of care. This is a lot of talking about quality of life, meaning of life, advanced care planning. This is a lot about talking about what to expect. I think people who are involved in healthcare have seen this a lot, where somebody comes in a crisis. They're in the emergency room, they're unresponsive. We've never talked to anyone about who their next of kin is or who they would want their decision maker to be. If they have a decision maker, they didn't talk to them about what they would want. They end up in the ICU, they're intubated, they're talking trach and peg and long-term nursing home, and they're looking at this daughter who's grief-stricken and in huge moral distress and says, what would your mom have wanted? And she says, I have no idea, right? So take that moment and go backwards. This is what palliative care does, right? Is if you're at risk of ending up here, how can we talk to you here and not in this crisis, right? So your daughter knows what you would want. So those documents are signed. So we've facilitated the conversation between the two of you. So we put things in place like higher levels of care and getting you connected with the providers you need and the best medical management you need to prevent you from having this moment, right? So a lot of people, that's not how they want to live their lives or end their lives. They don't want to end it in a crisis, in an ICU, in a hospital bed, connected to a whole bunch of tubes. So how do we make it so you're ending your life empowered, informed, and the way you want to do that? We have birth doulas. We talk about birthing plans and how women want that to look all the time, right? So this is very similar. This is growing old, aging, chronic illness, and yes, eventually death is 100% universal human experience. I know what I want my experience to be. I know what I want my parents' experience to be. And working in healthcare and seeing that people don't always get that is what inspires me to do this work, right? I want people to get what they want. And without being informed, without being empowered, that isn't something that can happen. So our actual care is about these conversations and the medical and clinical expertise we have to support you in navigating these decisions. Minda Ray, will the visits be to the patient's homes? Will any illness be helped, not just cancer patients? Yes, great question. So it will be kind of two parts in our outpatient setting. We'll have a clinic-based palliative care program in oncology that will see our oncology patients in clinic and will be embedded there. And the other part of the time is a consult-based community model. So yes, that is going out to patients' homes, that is talking to them, that accepts all illnesses. So this is different than the previous model in outpatient Bellingham. The previous model in outpatient Bellingham accepted CHF, COPD, and oncology patients. And those were the three diagnoses that they took. So with our new community-based consult model, we take all diagnoses, anyone with a life-limiting chronic illness. So that is happening right now and will continue to happen. Good question. Thank you. Eileen, can you please explain what happened with Peace Health Hospital in Eugene? How confident can we be that the same will not happen there? Was the palliative care shutdown indicative of other problems? So palliative care did not shut down in Eugene. The Eugene Palliative Care Program experienced a reduction in staff, like I said, as did hospice and home health. So all of our palliative care programs across the system experienced that, including Vancouver and Bellingham and Eugene. But Eugene never closed down. They are doing this exact same model. So they have a nurse practitioner, they have a nurse, and they have a social worker, and they are doing the consult-based model in Eugene. They have a good census, and they are also on track to see more patients under this new model this year than they did before the new model was implemented. If you're referring to something else in Eugene, please feel free to put it in the chat, and I'll see what I can do to answer that. But thank you, Eileen. Catherine, how did you determine that fewer visits per patients are predicted for 2024? Well, that's a great question. So it's really, when you're doing a consult-based model, right, you're identifying that acute need and seeing how many visits you need to get that need met. So there are patients that will be on, so it's an average. There are patients that will be on longer than those 3 visits, and there are patients that will be on shorter than those 3 visits. So for example, a lot of what we've seen with the consult-based model is we call to schedule the appointment. So we don't even know, we have their basic chart information and we're just calling to get you scheduled. And on that phone call, it ends up coming out that this person's really hospice appropriate. That's really what's most in alignment with their goals. We do the entire consult over the phone and then get them admitted to hospice within the next day. And so some people's visits are really done in that one initial consult where they just needed a certain missing piece to the puzzle to plug it in and to continue to go. And now we tell everyone, whether we have you on for 1 visit or we have you on, for 7, that if anything changes your goals, you're diagnosed with a new illness, you have a sudden event, you're readmitted to the hospital, you're presented with a new treatment option, and that's changing where we left you, call us back. We'll take you back on service. And so we have already served in the consult-based model since we started it, the same patients multiple times. So it's just really us holding them when they're having an acute palliative care need. And so the average is working out to about 3 visits. I hope that answers your question. Elaine, I have recent experience with palliative care here in Bellingham. They were excellent and made the transition to hospice very smooth. Thank you so much for sharing that. I really appreciate it. I think, I don't mean to get emotional, but I think one of the things that happens, and I want to say, I understand how it happens. I am so passionate about this work. It is so easy when we take a hit to say, this isn't fair, this isn't okay, I'm really mad, how did this happen? And, and as the director, I have that experience, when something doesn't go my way or I had advocated for something and, something else happens, right? And I think of what gets me to shift back to be present is these humans. At the end of the day, there are people in our community that need to go to hospice. There are people in our community that need to transition to this work. I'm going to tell a story about Katie. This is just her everyday life. She would not think that she's the nurse up there for outpatient, and she would not think this was special or exemplary at all. But the patient was referred to home health. So the provider said, I just need someone in their home. I know they need more help at home, essentially. Katie called to schedule the visit and started talking to the wife about what was going on. And very quickly, with all of her nursing experience and all of her healthcare experience, realized this patient is very, very sick. And she said, I am getting in my car and I am on my way to you right now. And immediately drove out to this house and did a full assessment on the patient and realized this patient is hospice appropriate and needs that. Is in symptom distress. Katie called hospice, got the hospice person out there within half an hour, signed the patient on, got their symptoms under control, and that patient died in his bed, surrounded by friends and family that evening. And again, Katie would not say that that's exemplary or above and beyond or anything, but it was a home health referral that wasn't even on our radar. And home health said, I'm not so sure about this one. And Katie said, let me call. And within 2 hours of that phone call from home health, that patient was on hospice. And within hours after that, that patient passed away at home, surrounded by their friends and family, completely comfortable. So thank you, Elaine. There are humans doing this work and there are humans impacted by this work. And so no matter what hits we take, I think we always have to remember, like, there are people that get up every day to do this because they love it. And there are people that receive this care every day because they need it. So thank you so much. And for Bellingham, I want you to know your patient satisfaction scores for our outpatient program under our new model are 98%. So we send out a survey with this new model to every family that receives the new model of care. And those results are 98% positive. So people are very, very happy with the care that they are receiving in Bellingham. Wendy sent a link. Wendy, I will look at that. Carol, how do we get a local Bellingham represented on the Peace Health Board? Are we being heard and our community members given some control for their care? Yes, I think this is a great question. I am not involved because I am running palliative care. I'm not involved in the intimate ins and outs of who is and isn't on the board. But I do know that this is a big topic of conversation about the board, the makeup of the board, the representation on the board, that there are a lot of different factors that go into, who needs to be on a board because healthcare today is so challenging and has a lot of distinct challenges for us. So they are looking for people with the right experience and the right mix of experience to other board members. But yes, this is something that's being talked about. And if Donna and Amber have additional things they would like to comment on that, you might have a better answer for this particular question.
I think that covers it, Leslie. Thank you.
Okay. Wonder if you are familiar with this, researchers. Again, Wendy, I will look at this link. I'm afraid to click it and have Zoom go away. Maybe use the money spent for prolific advertising for palliative care instead. We in palliative care have very little advertising. We don't really even have a budget for it. One of the things I do think is really important is to just get the truth and information out in front of our stakeholders and people who are invested in our program, so that they know what's going on, which is why I'm here today and why I'm so grateful to be invited and would love to come back and talk to you guys. That you're clearly very invested in palliative care, and palliative care champions is what keeps palliative care alive. So you guys are my people, and I'm happy to come back and talk as many times as you need to. But we don't have any specific advertising. We just go out and try to put our data and our good work and our messages in front of our stakeholders and our partners and the people we rely on to do the work. Is your social worker a Medicare provider? So our social workers, once you get your license, you can get credentialed to bill for certain services. So yes, Devin is in the process of obtaining her licensure. which is a lot of work. So I know because I did it. It's the equivalent of getting an additional master's degree. It's no joke. And the test for Washington is known to be one of the hardest in the country. So Washington really holds their medical social workers to a very high standard. But once you are licensed and credentialed, yes, you can be credentialed with Medicare, Medicaid, TRICARE, and private insurances. And they are able to bill for anticipatory grief work and counseling. Barbara, if we experience another COVID type hit on medical systems, is there a way volunteers could be trained and used? Yes, absolutely. And I love this idea. And I think it's a good opportunity for us to really revisit how that looked. With our initial pandemic, we didn't know. We didn't know anything. It was quite scary. There was no vaccine. There was no medications, to help. There was no antiviral. We didn't know. And our hospitals were full of COVID. And, I remember losing sleep. I lost a lot of sleep because I had to send my caregivers, my teams, these incredible people. I know their families, I know their spouses, I know their kids, I know their pet names. I know them. They're such incredible humans. And I had to send them in to do this work when we knew so very little. But we were the ones at the bedside talking to people about COVID and what would happen and trying to help friends and family prepare. And they couldn't come into the hospital either. So, volunteers got sent home for their own safety because we didn't know. I think, if it were COVID in particular, and we had another spike, right? People are vaccinated. We have a lot better understanding of how to keep people safe. And so it's a very different conversation about how to utilize volunteers than it was when it first happened. So great question.
And I'll just interject here that, through the hospice program, if you want to volunteer, we use volunteers for palliative care. If you go through the hospice training program and you're a volunteer there, you can also be a volunteer within the palliative care program.
Yep. And we love our volunteers.
Mm-hmm.
Kate. So we really need to be lobbying Congress to require Medicare to support palliative care financially. Please, yes, please, Kate, please, 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 please. And we have the perfect opportunity right now. The door is open in the state of Washington. This is something that's being talked about in the legislature. There is a bill right now talking about different reimbursement models for palliative care and getting that forward. And the more voices, the more support, the more push we have for that is huge for our work and would really put us in a place we'd never been before. We'd be having an entirely different conversation about how we function. And so, yes, please, please, please get involved. There are lots of ways to do that. There are lots of Senate meetings happening, and those things are open. As I come across them, I will try to get that information out to Donna too.
I can add at this point, although this is not my particular issue area, I do watch the healthcare issues in the Senate and the Congress. And yes, there is a bill there. I don't remember exactly when they're going to hear it. It's either today or tomorrow. And you may be able, and if it hasn't already been heard in the public hearing, you can sign in pro supporting the palliative care bill. And I put the number of the bill below there. And if you read the League of Women Voters, the newsletter, legislative newsletter that comes out on Sundays, there may be information about that in there also. And also in the email I sent out.
Thank you so much, Mary Lynn. Yes. And all involvement and support, it takes voices. This is what I've learned about palliative care. It takes voices, right? More voices we have, we just keep moving. And every time we get hit, we come back stronger and better. And this thing in the legislature right now is an example of that. There are more voices, more people are seeing, things are shifting. And so that's great. Please get involved. Thank you so much. Catherine, is there any movement to having more components of palliative care reimbursable by Medicare and Medicaid, as happened with hospice in its early days 40 plus years ago? Yes. I love this question because I say working in palliative care now is very similar to working for hospice, 40 years ago, right? It is, hospice started out, I call palliative care a group of concerned healthcare citizens, right? That's really what it was. It was all very grassroots. I remember, my first job, I was sitting at the hospital and thinking like, after my 50th conversation, had I known blah, I wouldn't have done blah and I wouldn't be where I am now. And I don't want to be where I am now. This is terrible. Like, okay. So after my 50th conversation of that, I just thought, I went back and I reviewed charts and I was like, you can kind of see this coming a couple of years before this moment you're having this conversation. We can do better. And so I recruited a doctor who held the same opinion and we figured out how to get a consult order and in the chart, and him and I started running around the hospital talking to people. That's how these things got started. And so we are in our own hospice evolution, for sure. So like I said, there are a lot of opportunities here to optimize our private payer contracts. Medicare and Medicaid always follow the big trends. So if you get all your private health insurance companies, doing something similar, Medicare will follow. So that's kind of where we're at right now, is we're in conversation with private insurance companies about the best reimbursement model. Private insurance companies know having their patients on palliative care saves them money. Now, we're not out to save people money. We're not out thinking about finances. We're out thinking about doing what's right for the patients. But a very happy accident side effect of good quality clinical palliative care is there is a cost savings to it, to our hospital system, to insurance companies, to patients, to families, mostly because when people are fully informed and empowered about what's going on, they opt out of some of these really aggressive things that are going to have poor outcomes. And that saves health insurance companies money. We know that the last 6 months of life in America is the most expensive times 5. It's really astronomical. We know in America, our GDP is at 20%. The country closest to that is at 11. So we really do have a health spending issue. And services like palliative care that are value-based are part of the solution. And insurance companies, private insurance companies know that. So they are engaging in conversations with us about bundled payments, value-based payments, and per member per month payments. And so that is just starting to happen. Those conversations, those doors are opening, right? Once we get there, once we get that established, once that's our norm, Medicare will follow. I can't give you an ETA on that, but I just know Medicare follows the trend, but they are the last to follow, which is a tricky spot for us because it will always be our biggest payer source. But yes, I do see that in our future, and it is something we are actively working on. Naomi, define life limiting on a time scale, like hospice is less than 6 months life expectancy. Can someone with dementia get palliative care? That's a great question. So hospice is prognosis specific. So prognosis is the time we believe that you have left to live. So to be eligible for hospice care, 2 physicians have to say, if your condition took its natural course, you would have 6 months or less to live. Palliative care is not prognosis specific. So you need a life-limiting illness and you're somehow having a palliative care need. So difficulty managing the system, a resource that could better help you live successfully in the community, needing more information about your health condition, needing to, come up with a next of kin and decision maker and talk with them about that. You have a life-limiting illness and you're struggling to manage it, I would say, where we could help you with that management part. Well-managed people in the community with a chronic illness might not receive palliative care because they're doing well with their chronic illness, right? But people who need something, right, and have a life-limiting illness qualify for palliative care, would be happy to come out, admit you, and see you. And then, like I said, for dementia, which is a chronic illness, sadly, it it is the long goodbye. My grandma died of Alzheimer's disease. I watched that. I was her caregiver for part of that time there at the very end. It is an excruciating disease. I sat on many dementia boards. I did dementia support groups across Portland for all of the memory care facilities for a long time. This is something I believe very strongly in. So anytime there's a new change, anytime there's a flare, anytime that acute need comes back up, call us. We'll come see your loved one. We'll get you set back on your track to stability. The second any of that changes with dementia, we'll come back out again. Wendy, specifically, how would this model serve patients with Parkinson's and other patients with neurological conditions? That's a great question. Very, very similarly, right? What is your acute palliative care need, and how can we best serve you? Now, what I will say with some of these neurological conditions, Parkinson's, ALS, things like that, usually the biggest need we see from a palliative care perspective is to the families. Once you get the patient kind of hooked up to what it is they need to do their day in and day out life,
14, 16,
and with a specialist
18, 20.
to monitor their care, a lot of this is just about supporting families, because these are very hard diseases to watch people go through. So making sure we can help set up people with the ongoing support that they need for these conditions is going to be a big part of that. Sherry, does Medicare pay decently for hospice care? Well, here's how hospice care is reimbursed. So there are 4 levels of hospice care. So there's routine care, which is how most of us think about it. We come out to your house and we see you. You're surrounded by a multidisciplinary team. We manage your symptoms. That has a daily reimbursement rate for hospice. So what happens a lot with hospice, however, which goes back to something earlier that I was saying about outpatient palliative care increasing hospice length of stay, and this is why this is important from a financial standpoint. Now, it's important from a clinical standpoint because it's best patient care for them to be on hospice and stable and home with their loved ones for as long as possible. That's best, but it also has a financial impact. What happens a lot is people get referred to hospice too late. And so we send out everyone, we do the admission, and then the patient starts transitioning to the active phases of dying. Now, the admission process of hospice and the death process of hospice are where we have to send out everyone to really care for you. So that is a very costly part of hospice. So those patients that get admitted late and die quickly, there's no money made in that. There's money lost in that, right? From a financial standpoint, again, this also has a clinical benefit. It is just best care for our patients. But the financial benefit is if you have somebody admitted and they have a stable period before they decline, they do get a daily reimbursement rate, right? And so that can kind of backfill the expense from the admission and backfill the expense then that's going to come from the death, So hopefully then we break even, maybe even make some profit. And the profit then goes to supporting things like palliative care. Because we support them in having a longer length of stay. So we have this very symbiotic relationship with hospice from a financial standpoint. Mickey, I believe Carol was referring to PCEL's system governing board, not the foundation board. Okay, again, I'll let Amber or Donna take that question. All I know is that, yes, this is being looked at and discussed.
Yeah, I would second, I know people are talking about this. I also think it's important for people to understand that the Peace Health Governing Board is not geographically based. It is skills based. So like a lot of big boards are, they're they look at the skill set that they need on the board. They need a doctor and nurse. I'm making this up, but whatever the specialties are, you know, an ethicist, somebody from, you know, eventually all these boards are probably going to need an AI person, right? Or a tech person, so that they can really have a well-rounded breadth of knowledge that they bring to the board. So it's not like some other boards that are geographically specific and looking to bring in people from an area. This board is a skills-based board.
Okay, and I don't know if this is a question, but or if I'm missing who the comment was connected to, but Peace Health takes actions that fail to address the wishes of the patient, i.e. assisted suicide. Yeah, I'm not sure the question specifically, but that's also something that's changing a lot. It is hard, it is challenging in a healthcare organization with a Catholic-based focus, because we really do believe in the preservation of life. And that is where we were founded with our sisters of the Justice of Peace. That being said, the couple of things that have changed is we're now allowed to document patient first request, where that was not the case. So that's a really big, important deal. Documenting first request means that sets the clock. You need to make 2 requests within a certain amount of time to be able to get that, and you need to be in a medical position to be able to administer the medication to yourself. So the earlier that first request is documented, the more likely the patient is to be able to get it. So now as Peace Health providers, we are able to document that first request, and that is a big change for our system. The other big change for the system was for hospice care. We were told that we couldn't be present for this. So now we need to step out of the room while the medication is being administered. But as soon as the patient has ingested the administration, we can go back in and provide care and continue to make sure that their end of life is comfortable and peaceful. And so that's also a big shift for us and enables us to really surround the patient through that process. So as an organization, we're very happy with that evolution and that discussion around this topic and honoring the different ways patients have to request this.
I think that the question that you just read referred back to an earlier question, which that said, how will Peace Health deal with a person needing help who has stopped eating and drinking to facilitate their exit?
So voluntarily stopping of eating and drinking is something that, you know, people choose to do. And the CMS criteria for hospice is the same. You know, at some point, if you stop, there are some people who stop eating and drinking, and it does take them a little bit of time to start to meet the hospice criteria for debility or failure to thrive or some of those things. Once you meet the hospice criteria for that, then we will admit you to hospice and support you on that end too. So voluntarily stopping eating and drinking is a decision patients have the right to make. I must have missed that question along the way. I'm so sorry. I'm trying to go question by question.
Yeah, and maybe that wasn't really related to that question, but I thought it might be, so I brought it to your attention.
Wendy, I just sent a question related to the link I sent. Thanks. I didn't see that question. I must have missed your question, Wendy. If you want to come off mute.
I can scan and find it while you maybe answer the next one.
Yeah.
Okay, next question. Peace Health advertises in every local publication every month, as far as I know. Oh, okay. So is this related to a previous question? That's interesting. The Bellingham community, because Peace Health is such a large part of your community. So unlike the Columbia network, right? We have Kaiser, we have OHSU, we have Legacy, we have Adventist. There are a lot of different options for choosing your care in the Vancouver area or the Longview area. And same with Eugene. Eugene is really interesting in that they have 5 different community-based palliative care services you could pick, for example, right? So your community is very different that way. You know, the biggest provider of healthcare services in Bellingham is Peace Health. And so they do publish more than the other areas do, for sure. They really value trying to keep the community informed to the best of their ability about things that shift and change, because there is that acknowledgement that this is where most people are going to go for care. And that isn't true in our other areas. Our other areas are not, don't have publications going out into magazines or articles or journals or things like that the way Bellingham does. So that's correct. And I think that's the reason behind it, is that community is different in that way. I think she's talking about Peace Health's advertising overall, not palliative cares itself. Thank you. Yes. Thank you for your work. It's clear you and your team have a great heart for this. Thank you, Julia. Yeah, like I said, it reduces suffering, and that's what it's all about. And it's really important work. And I want people to know, if I were going to give up on palliative care, I've had many opportunities where it was hard, over 20 years, where I could have walked away. And I'm not going to. I'll never give up. So a lot of people pick a mission to work on their whole life, and this is mine. And I feel fortunate enough that I work in an organization where other organizations chose to cut their palliative care program completely, that I work in an organization that kept it, and that I work with people like you who continue to be champions for it, and to rebuild it. And without all of us holding a light together, we wouldn't be here, and people wouldn't be getting this care. So thank you. But I will never give up on people who need this care, and I will never give up championing for people like you who believe in it and invest in it. I am here, and I am not going anywhere. This is what I do. Thank you.
And I am so glad to hear that. I think it's about time to wrap up. We asked you for an hour. You've given us an hour and a half. We're very appreciative. Thank you very much. Maybe I just read one last thing. There's some more questions, and I will forward them on. But want to read one response. Thank you for your work. It's clear that you and your team have a great heart for this, and I think that's been very apparent to us today, that you're very invested in this. This is your passion, this work, and I appreciate your coming today and talking to us about this. And I will follow up with a couple of questions that are still in there.
Great.
Thank you very much.
Thank you.